हेलो सईद, हाउ आर यू?
अलहमद साहब कैसे ठीक है सर।
अल्लाह का शुक्र। वो किधर है भाई, नासिर भाई?
सर वो अभी बात हुई है सर से, सर कह रहे हैं कि मैं ज्वाइन कर रहा हूँ।
लगता है पीसीआर करा रहे होंगे। मैंने उनका रिकॉर्ड लगा लिया पीसीआर का। वो जो है, अच्छा, खैर चलो, अभी टाइम है, सो जस्ट वेट। ओके।
जी जी सर। सर खालिद भी हैं सर, आ गए हैं।
जी सर, थैंक यू। अस्सलाम वालेकुम सर।
वालेकुम जुनेद, सलाम वालेकुम। कैसे हैं आप?
अल्लाह
ठीक
का
हैं?
शुक्र।
कैसा
अल्लाह का शुक्र,
कै,
बिल्कुल।
कै, कैसा कैसा है मौसम टोरंटो का?
आप बस, ऐसा मौसम है कि आप, मतलब बहुत ही जबरदस्त मौसम है। मतलब इस मतलब इस काइंड ऑफ के इस वक्त फुल शाइन है। और
हम्म।
टेम्परेचर इज अराउंड 21-22।
ओह,
और
वेरी नाइस, माशाल्लाह।
हाँ, तो जो है बाहर अभी, मतलब इट्स अ परफेक्ट वेदर फॉर आउटडोर एक्टिविटीज।
वेरी गुड,
नासिर आ
वेरी
गए हैं
गुड।
सर।
जी
वेलकम सर।
नासिर, सलाम वालेकुम। नासिर,
Yes, can you hear
सलाम
me?
वालेकुम। यस, वी कैन
Wow.
हेयर यू।
Hold on, hold on. Let me connect my. Let me connect my.
स्लाइड्स। जी जी।
Hopefully, it is connecting. Give me a second. Um, can you guys hear me?
या नासिर, वी कैन।
You can. Perfect. Very good. Very good. So there are some technical difficulties. I'm trying to address those, but bear with me for a second on my end. Okay.
या, टेक्निकल डिफिकल्टी इन शेयरिंग द स्लाइड्स और समथिंग एल्स?
Yep, sharing the slide. So let me work on it. You guys can continue talking. Give me just 1 minute, okay?
वी आर जस्ट टॉकिंग अबाउट वेदर।
Oh, good for you. Good for you. Good for you. Present on this device. Yes.
सर तलाल इज आल्सो विद अस। वेलकम सर।
Welcome. हाँ जी, क्या हाल है जनाब?
तलाल, सलाम वालेकुम।
वालेकुम सलाम।
तलाल नजर नहीं, ये रहे
आ
तलाल।
गए सर।
तलाल, हाउ आर यू?
जी, अल्लाह का करम, खैरियत से। बिल्कुल, आप खैरियत से हैं जुनेद साहब?
बिल्कुल, अल्लाह का शुक्र।
ठीक है, बिल्कुल
तो
बस।
नासिर साहब की कोई टेक्निकल वो है?
नहीं आ
अच्छा,
गई। I think I can share.
हाँ, यू कैन शेयर नाउ।
Photos. Cancel. Let me share. Box bookmark. OneDrive. Let me do it this way. Open up the slides.
कपड़े वपड़े निकालो, जाओ चलो।
What is the meeting ID number? Let me see.
You cannot share without ID number.
I don't know. That's what the problem. I think you guys have
ऑलरेडी सर,
the
आई ऑलरेडी ओपन द शेयर स्क्रीन फॉर पैनलिस्ट।
okay. Okay.
Okay, now you try.
Okay. Let me try it now because I think he wasn't. That's what I was thinking. That why I'm not able to share it. Okay. Share photos. I drive Microsoft. No, it is not. It is not letting me do it.
चेक
Do
नाउ
it on my
सर। सर नाउ सर अब चेक करें सर।
website. Google Drive, photo, iCloud Drive. I think it's a panelist thing. Let me do it this way. मैं ऐसा करता हूँ तो मैं you have an email?
यस सर।
Okay,
Nasir, I can able to share the screen. What you can do, just rejoin.
okay. Log out and rejoin.
Yeah,
Okay. Okay, perfect. Let me do it this way. Leave.
and Saeed, keep him as a panelist. Okay.
जी सर, जी जी सर।
I do not have a share screen order option on my end.
Can I share your screen?
Yes, I don't know because I can share the screenshot with you. I have back to webinar schedule, but the share screen icon is not opening on my end.
Sir, here.
Eh, Anybody can see the screen?
Ji,
I
sir.
shared.
I can see the screen. I can see the screen now. Perfect. I think
So
we are good.
everybody shared. So just let me know when you want to make a slide change, okay?
Perfect. Very good. Very good. Whenever you guys want to start, I'm more than happy to start.
So should we start, Sir Junaid?
Ji sir, what time is it? Just give 1 more minute and then
Okay.
start. Okay.
Sure, sir.
So how's the weather on your side, Junaid?
Excellent. I am telling Dr. Haq
Oh.
that it is 21, 22, full sunny sunshine. So it's a perfect for outdoor activities. You can run, you can walk, you can, So after that, I will take out the kids to somewhere. Okay, so go ahead, Saeed.
Sure, sir.
I'll share the screen in full.
Sure, sir. Thank you so much, sir. Bismillahirrahmanirrahim. Assalamu alaikum to everyone, all my respected senior teachers and my dear colleagues. Today, we are going to discuss another common and hot topic, and we all were waiting, especially for this topic, since I think 2 weeks. So today our speaker is Dr. NASIR RASHID. He is a senior neonatologist and pediatrics medical group hospital affiliation, ST Rose Dignities, Sina Henderson, Nevada, and Mountain View Hospital, Las Vegas, Nevada, and Southern Hill, Las Vegas, Nevada. And all the time active on the academic group and all the time available for any kind of information related to the neonatology. So today we all will learn from Sir regarding the neonatal herpes encephalitis. So over to you, sir.
Assalamu alaikum. Can everyone hear me?
Yes, sir.
Okay, perfect. Very good. Very good. Thank you very much for the introduction, Saeed. You give me more credit than than I needed. But can we go to the next slide, please? Okay, so what we are going to do, the reason we are doing this discussion is primarily that we do not have herpes PCR available in Pakistan. And the question was that how we can use the clinical information and any data that is available to understand this disease and its process, and how we can apply it in managing infants and children in Pakistan. Obviously, this is not for children, but I'm going to just use the term infant up to the first month of life. So for us, for me to give you a better idea what herpes is, we are going to talk about the mode of transmission, and we are going to go back in time when we were in 3rd and 4th year of medical student, and we learned microbiology and mode of transmission in microbiology books. We will discuss the clinical presentation, we'll discuss differential diagnosis, what are the treatment options that are available, and its Pitt's wall. Okay, next slide, please. So the herpes virus family is a big family, and there are, I think, at least 8 or 9 viruses. Don't quote me on that exactly, but there are 3 that I think are very important for all of us. And I'm going to talk about the 2 of them in the next subsequent slide so that you understand the mode of transmission. Once all of us understand the mode of transmission, then it will be much easier to apply what we learn in the 4th year and 3rd year in med school, in the clinical setup, and how we can help these families when we do not have the luxury of doing herpes PCR or culture. Next slide, please. So I'm sure most of you may have watched and know this person in the picture. This is Brad Pitt. This is a movie called as like World War Z, and the basic theme of the movie was that there's something happening and everybody's becoming zombie. And as the plot unfolded, it turned out that it was a contagious virus that was being transmitted from person to person just by coughing. And they mentioned, actually, during, if you have watched the movie, they mentioned Zooster and chickenpox as the closest virus of this kind of, and they are trying to understand the virus in the same way they understand the varicella zoster virus. So remember, varicella zoster is transmitted, although it's part of the herpes family, by a droplet or a very contagious way. Next slide, please. Now, the another virus that is transmitted the same way, but it is not as contagious, is Epstein-Barr virus, although it's not common in infants, but it is common in children, and it is also transmitted through droplets. And the person in this picture is actually Mark Cavendish. He is a very famous bicyclist, and he was about to break the record of Eddie Merckx of winning 34 Tour de France cycle races stages in 2017 until he caught Epstein-Barr virus during a cycle race. And he wasn't able to break the record for the next 2 years. So these two viruses, as we discussed, varicella zoster and Epstein-Barr virus, are transmitted through droplets or respiratory contact. Remember that part. Next slide, please. Now, cytomegalovirus is a perinatal, like an in utero transmission, and most of us are aware of what cytomegalovirus is and the congenital infection. And I'm sure most of us have seen at least one or two of those cases. So among the three viruses in the herpes family, the first two we discussed are respiratory. The cytomegalo is more commonly transmitted as an in utero transmission, especially in the neonatal and early phases of life. Later on, I think every one of us acquired it at some point in time. But going to the next slide, please. Yeah, so next one is the herpes virus. So herpes virus are two types of viruses, type 1 and type 2. Type 1 cause oral cold sores. And the first sentence says oral cold sores and encephalitis in children. I use the word occasionally neonate when I was making this slide, and I thought it is probably uncommon, but as we will discuss in the subsequent slides, neonates can get type 1 herpes encephalitis, and we'll discuss the mode of transmission. Type 1 can spread via contact with a cutaneous herpetic lesion, and we think it's an oral cold sore, so this is how it can be transmitted. Type 2 causes genital lesions only in adults, and the infection occurs exclusively in neonates who are born to the mothers who had genital herpes. The spread will happen either by a skin-to-skin contact or a very intimate contact. It cannot happen just randomly. It has to be a very intimate contact between two adults. And the neonatal encephalitis is typically manifestation is viremia and a global brain on involvement. That is one of the presentations. We'll talk about the subsequent other presentations of herpes in infants. And is always required during perinatal exposure during labor and delivery. So the mother has to have either a viral shedding or some kind of a lesion, and the baby has to pass through the birth canal for the baby or the infants to develop this infection. Next slide, please. So this one is the, I took it from an obstetric literature, and look at these lesions. You can save it as a reference for you guys to have a little bit of understanding of the concept of how does it appear physically. They are small, painful red blisters, usually around the genitalia. Distribution is around the private parts of the adults, whether it's men or women. There's a history of itching, and the lesions usually occur 1 to 2 weeks after the primary infection. So a person can get an infection but may not have lesion for at least 1 to 2 weeks. So remember that part. And remember this picture, we'll circle back on the next subsequent slides. Next slide, please. Now, if you look at the clinical picture, the way they present is, and I'm going to go through this list, is pretty much any way any infant will present with sickness or illness. They can be alert, they can be lethargic, comatose, and we are talking about neonatal herpes infection, whether disseminated or encephalitis. So, as I said, can be alert, can be lethargic, comatose, semi-comatose, sleepiness, altered behavior, poor feeding, can be have seizures, focal or generalized, can have fever. Fever is usually not a typical clinical picture of herpes, but it can be. Herpetic skin lesions are always associated with encephalitis, and that's why I marked it in with a different font and color. Tremors, altered liver functions, and thrombocytopenia. By the way, on the bottom of every slide, the reference where from I have taken these points are in the bottom as a reference. If anyone needs those articles or slide references, feel free to ask me after the presentation. Next slide, please. So what are the differential diagnoses? If an infant is presenting with fever or no fever, but with focal signs and seizures, it can be a sodium imbalance, hypo or hypernatremia. It can be hypoglycemia. It can be calcium imbalance. I included HIE in the differential diagnosis because while talking to you guys in the last 1.5 years over the forum, it turned out that HIE is pretty common and present in the tertiary care setup, commonly at seizures or poor feeding or lethargy and all those signs. So when an infant is presenting with all those signs, besides focusing on this being herpes encephalitis or disseminated herpes, think about these diagnoses. Early onset or late onset neonatal sepsis will also present in the same way as it presents with herpes infection. Now, these zebras, and actually a few of those, I don't even know exactly the third one, the dihydropyrimidine dehydrogenase, I don't even know how to pronounce it. So I would suggest to all the fellows that or junior faculty member or residents and medical officers that before embarking on going for these differential diagnoses, think about the common that we talked about. Next slide, please.
Nasir, one thing. These differential diagnoses are particularly of neonatal encephalopathy or the herpetic encephalopathy?
So neonatal encephalopathy, and we'll talk about
that's what I'm saying. It is not
Yep.
particular to the herpes, huh?
Nope, not particular to. But I thank you for pointing this out, because in the subsequent slides we'll talk about it, that how to narrow it down to
Sure,
herpes.
sure.
Okay.
Okay.
So next slide, please. So all of you know that I am always about the pertinent data collection, because until and unless you have the full data, and this is the clinical data collection that I'm talking about, and then we'll go into the lab work and everything. But when an infant is presenting and you started thinking this is herpes or one of those differential diagnoses, then the clinical picture that we talked in the previous slide is going to be combined with the pertinent data, so then you can narrow it down to first couple of few diagnoses. So you will ask about the antenatal course, how many visits, birth history, cord prolapse, placenta previa, did infant cried at birth, because HIE will also present like that. And you, until and unless ask those questions, a 3-week-old infant presenting with seizures and fever and lethargy and sleepiness and comatose and semi-comatose and all those things, you would say, oh, this can be herpes or this can be HIE. Until and unless you ask those specific questions, you will not know for sure. Having said that, an infant can have had an HIE at the time of delivery and later on develop herpes as part of a superimposed disease. So be mindful about those things. Talk about the feeding. How was the infant doing after birth? Because the onset of neonatal herpes or neonatal infection is a little later, not at the time of birth. Even if the mom had active lesions in the genital area and the baby was born vaginally, the infant will not acquire the herpes right away. Even if it acquire the herpes right away, the clinical symptoms will not appear for several days, and we'll talk about it in the subsequent slides. Number of wet diapers, jaundice, progression of jaundice, onset of there are petechia and purpura, when did they started? And then the most important question, if you are taking your diagnosis toward herpes, is the history of any genital lesions. And this is where I think the important thing is to ask specifically mom in private by somebody, should not be asked in the middle of a unit with 15 people walking around, should not be asked in front of the husband. It has to be done by a female physician or a house officer or somebody who is very mindful about it. Pull the mom very subtle, in a subtle way, to a corner and ask her if there's something that could have pointed toward this being herpes. And then obviously you have to do an examination of the mother just to be sure about it. Or as I said, showed the picture, somebody can show it to the mom and ask her if she had anything like that in the past. One thing that I want to clarify, and this is only in the Western setup, I'm not sure about in Pakistan, but when usually at the time of delivery, most of the OBs prefer to have the pubic hair being removed. So a lot of women develop those razor burns and bumps, and they can appear like that few days later. If a mom had a delivery and somebody removed those hairs with a razor, a few days later, those razor bumps can appear like that. So be mindful about all those also when you ask the question. The next slide, please. Okay, so this is the data that I took from an article that was published from Baltimore, and I think this was back in data was collected between 2012 and 2014. This is a population of about 576 infants that presented with suspected CNS infection in a center over the period of 2 years. And they were in, their age of presentation was in median was in like 12.5 days, ranging from 6 to 27 days. So I wanted to use this data to give you an idea how common or how prevalent presented over the period between the 6 and 27 and were suspected to have a CNS infection. Next slide, please. The 16 had actual bacterial pathogens identified. All of them underwent lumbar puncture. 16 had bacterial pathogens, and you can see the common offenders, GBS, staph. 21 cases where they out of those infants between the ages of less than in a city like Baltimore, which has 37 had actual some kind of a viral or bacterial pathogen identified in this. Actual herpes. Minded all these underwent the specific studies, the bacterial culture, the viral culture, and the herpes PCR. So only. Now, if you look at the CSF characteristics, and this is only in this patient population of 576 with 37 actually having any infection. And if you look at the CSF pattern, the WBC count wasn't terribly high. Look at it, like between 4.3 to 198. Protein concentration was like 0.37 to 0.69. So they were picked up pretty early in their infection phase. So remember that only the CSF analysis is not a short way of diagnosing any kind of CNS infection to confirm it. But the Junaid, if you may be able to magnify. Let me walk through. So I'm sorry about the smaller font on this because I copy and pasted it. But look at it, this is a case where 23 and ended up developing growing listeria by a very special test that they did, was called as multiplex molecular panel. I don't know whether it is available in Pakistan or not, but the reason of sharing this case is that if you're suspecting a CNS infection or encephalitis or anything, and you are drawing the labs, and you are thinking of bacterial pathogen, and it are not those are not grown in your CSF sample, listeria is also a probability, and we'll talk about it in the subsequent slide why I shared this case. Next slide, please. Now, this slide needs a little bit of attention from all of you. These are terminologies that I want all of you to understand. It may or may not be applicable in Pakistan, but if you understand it and apply it clinically in Pakistani setup, you might be able to have a little bit of a more confidence in treating in these infections if you're suspecting this as being a herpes infection in an infant in Pakistan. So any adult acquiring herpes simplex 1 for the first time, or herpes simplex 1, 2 for the first time in his or her life, without a prior exposure to any of those viruses and no preformed antibodies, it's called as a first episode primary infection. First infection, either herpes 1, herpes 2, no antibodies, primary infection. Now, on the other hand, if an adult had a herpes simplex 2 infection already, but had antibodies of HSV1 or vice versa, then it is called as a first episode non-primary. So we talk about two kind of infections. First episode primary, same virus, no antibodies, first episode primary. Same virus, antibodies to the other virus, first episode non-primary. Reactivation means you had virus in your body and the virus gets reactivated anytime your immunity is a little bit suppressed. It is called as reactivation. Symptomatic shedding means the adult will have lesion like oral cold sores or genital sores, and also at the same time shedding the virus. And so the last and the least one is subclinical shedding, where the antibodies will be there, the herpes can be confirmed by the PCR, but they will be subclinical shed. Okay, next slide, please. And this is more of the, what do you call it, the good way of documenting it if you have PCR and antibody testing available. So as I explained in the previous slide, first episode, and you did the PCR, you check for the antibodies for both of them, and antibodies are negative, then it is first episode primary, and so on and so forth. So this classification is important for all of you to understand, because the implication of transmissibility is different for each kind of infection. Next slide, please. Now, if you look at this one, this is actually a lot of data. 58,000 women were delivered in a setup where culture was done within 48 hours. Herpes culture was done in 48 hours in 39,000 plus. Subclinical shedding was diagnosed in 128. Serologies were available in 121. And out of those one, the first episode, remember the first episode primary, where the lesion appeared for the first time and no antibodies of any kind, there were only 23 cases. So out of 39,000, 23 had first episode of any kind of genital HSV. And 57% of those, look at the bottom three boxes. Just go down to skip the medium boxes, middle boxes, go to the bottom three boxes. And on the left-hand corner, it said 57% of the exposed unit developed HSV disease. So any infant who was exposed with the first episode primary, means mother had the first episode with no antibodies, 57% of those units developed a full-blown HSV disease, whether disseminated or encephalitis. And then if it were first episode non-primary, which means antibodies against one virus and PCR for the other virus, only 25% develop the HSV disease. On the other hand, if you look at the right box on the right-hand corner, and the most smallest box on the bottom, 2% of the exposed infants were in women who had recurrent herpes. On scheme, 39,000 were screened, 121 were positive for herpes, 23 had primary episode or first episode, I'm sorry, and then 98 were recurrent. And recurrence has the least chance of transmission to the infant. On the other hand, first episode primary and non-primary may have 57% or 25% chance of transmissibility to the fetus, to the infant. Next slide, please. Now, these next 4 slides, Jeanette, you can skip through the first and all 3. Next slide after this one. And no, previous one before this one. Yeah, so this was a big table. I split it into 4 slides. You will have it in my handout. And any fellow who thinks that they want to develop a program, or an attending, or anybody in Pakistan who wants to develop a program of herpes testing in their setup, in the bottom of this table, there are websites, 1-800 number, where you can call and get those PCR kit or ELISA kit or antibody detection kit. I think that would be a good thing if bigger places or cities like Pindi, Islamabad, Karachi, Quetta, Peshawar, they develop something like that, where this would be a good service for the community, that, you know, like if you can develop something like that as a part of a testing. So next slide. Now, prevalence of HSV, risk, and actually we are going to talk about it also in other subsequent slides. Interestingly, herpes 2 is highest prevalence is in Africa, actually more higher than United States, Canada, Europe, and the least incidence of HSV is in Asia. And I'll show you in the next few slides and in the subsequent slides. And HSV1 can also now cause genital lesions and neonatal herpes. And the reason is orogenital sex. And we will discuss the answers from Dr. Whitley that I sent him, the questions at how it can be transmitted in a setup like Pakistan. So the type of the maternal infection, we already talked about it. First episode primary has the highest risk of infection to the infant, 57% versus first episode non-primary, which is about like 28%. Remember the whole boxes that I showed. And recurrent has only 2% chances of transmission to the infant. Maternal HSV antibody status. So I'm sure by this time you guys know that primary episode, the reason of transmissibility higher is that there are no maternal antibodies. If there are maternal antibodies, the risk of transmission is less. Mode of delivery. Vaginal delivery has a higher chance of transmission than C-section. Prolonged rupture of membranes and ascending infection can cause HSV infection in neonate. The cutaneous barrier may not be an issue in a country like Pakistan, because I don't think so fetal scalp electrodes are used. But if there's any reason for barrier breakdown of infant skin barrier, then think about it, that and if mom had herpes, it can be transmitted through that skin lesion. And then obviously, this is interesting. I did not know this part. This is actually a new news to me. I learned just while prepping for this slide. HSV1 has a higher transmissibility rate than HSV2 to the neonate from mother. So remember that also. This was news to me. I did not know this. Next slide, please. Mode of transmission, again, we talked about it. Peripartum is the highest. Postnatal can happen if there is a caregiver to the infant who may have oral cold sores and they're constantly touching the baby or kissing the baby. That can cause transmission. But peripartum is the most common, is 85% of the time. Clinical presentation is disseminated disease, CNS disease, or skin, eye, and mouth disease. Okay. Next slide, please. So natural history, and this is where I think, remember that whole pertinent data collection thing that I was talking about, is that neonate with disseminated or skin, eye, and mouth disease typically presents between day of life 10 to 12. CNS disease typically present between the day of life 17 to 19. Overall, 50% of the disease will have some kind of a CNS involvement, and 70% will have characteristics vesicular lesions, like in skin, eye, and mouth disease, 83%. CNS encephalitis, 63% will have vesicular lesions, and disseminated will have 58% of infants with disseminated disease will have characteristics vesicular lesion. So I'm hoping, and let's take a break here before we go to the next slide, is that I am hoping that the concept of first episode primary, first episode non-primary is clear to you. The concept of HSV1 and HSV2 transmissibility is clear to all of you. The concept of a good history taking and a good examination is clear to you, that although not every baby who has herpes will have clinical characteristics vesicular lesion, look at the preponderance of vesicular lesion. And then obviously a good clinical history from the mother in a very confident way, and asking her privately to understand that if she may have had an infection that you are not aware of. And then if you combine all those data, then you might be able to have a little bit of more clarity in terms of whether it's herpes or not in a setup like Pakistan. Next slide, please. So this is
Nasir,
yes.
because you summarize all this thing, do you want me to ask you something now or in the later?
Oh yeah, sure. I think there are 4 questions, so I can take a break. I'm more than happy. I think most of these questions that you guys will have, they will be answers. But go ahead and ask me a question.
No, first ask the Saeed that do we take the question later or we can?
Sir, as you wish, sir, I have no problem.
Okay.
I know you no problem. Okay, so let's continue and then we will take. Okay.
Okay. And again, feel free to interrupt me anywhere where you think you have a question. If I have not explained a slide in a clear way and you want me to stay on that particular slide, because the next 4 slides are going to be a little bit, they were complicated even for me. So I don't want to rush through those 4 slides. But again, if there's any clarity that you guys need, please stop me. Okay.
Sure. Sure.
Okay, so this is the data that I actually copy from a very landmark study by Richard Whitley. He is the infectious disease specialist in Alabama, and all the herpes related literature is published from Alabama, and we'll talk about in the subsequent slide. So this was a very good study done to understand the survival and all those complications of a neonatal herpes. And if you look at it, on the vertical axis or y-axis is the proportion of surviving, and on the horizontal or x-axis is survival in days up to 1,000, from 0 to 1,000. And there are 3 lines. The first one is the skin, eye, or mouth disease. There were 85 infants in this category. And if you look at it, it's a straight line with no dots, nothing, no blur or anything on it. The second side, the line is a CNS, a horizontal line is a CNS infection with 71 cases. And if you look at that horizontal line, you see there are small dots or gray points on those, and each represents a mortality, okay? And if you go to the third one, which is disseminated, which is the bottom horizontal line, and you can see there were 46 infants in this category, and you see a lot of open squares in that, and each square represent a mortality, okay? So this is the survival graph that we are talking about. Next slide, please. So if you made a mental note of the previous slide, you can easily see that mortality was greatest in the disseminated disease. 26 out of 46 babies in the disseminated disease, of 57% died. And 15% or 11 of the 71 babies with CNS disease died. There was no mortality in the skin, eye, and mouth disease. Okay, so highest mortality in the disseminated disease in that study, and that is considered as one of the landmark studies. 15% in the CNS, and then no mortality in skin, eye, and mouth disease. Okay, and remember when we were talking about the pertinent data collection, I talked about alert, lethargy, comatose, and semi-comatose. You will understand why I was emphasizing about this, and in the pertinent data collection, because the next few slides will show that what was the reason for that. And the duration of disease was like 4.4 to plus minus 4 days, and disseminated had the same date and distribution than CNS disease. So the duration means by the time the baby presented with the time full-blown infection, or the time the mother noted and full-blown infection, it was pretty much the same in all of them. And this was done in 1991. Next slide, please. Now, same again. This is a survival based on the clinical presentation. Remember my pertinent data collection slide? I was asking about alert or lethargic, comatose or semi-comatose. So now we are not talking about skin, eye, and mouth disease because there's no mortality in that clinical presentation, but the mortality is highest in disseminated, and then followed by the CNS disease. Now, in the CNS disease, there were the out of the 58 cases presented either with alert or lethargic. Okay, that is the first line. Okay, and then the second line is the disseminated alert or lethargic, which were 30 cases. Okay, CNS semi-comatose or comatose were 13, and disseminated semi-comatose or comatose were 16. So what the author of this study have done was that they divided these two disease categories into alert or lethargic, that was one group, comatose or semi-comatose was the other group. And then they put these disease clinical presentation into those age groups. And next slide, please. So then outcomes were correlated with the level of consciousness at the beginning of therapy. Okay, and that's why remember pertinent data collection slide was about alert, lethargy, comatose, or semi-comatose. And then what they saw is that 9% died who has CNS disease that were alert or lethargic at the time of presentation. So CNS disease was confirmed by herpes PCR, but the clinical presentation they were either alert or little bit lethargic. Okay, but 46% of the CNS disease died if they present with comatose or semi-comatose. So the severity of the illness or the comatose, the state of alertness has correlation with mortality. Okay, and then when infection was disseminated, 43% had a mortality in alert and lethargic group, and 81% of the neonates who presented with disseminated disease and they were comatose or semi-comatose, they die. So there was a higher mortality in the semi-comatose and comatose group and lower mortality in the alert or lethargic group. Okay, and that's why it is important to document it at the time of presentation if you're suspecting herpes. Next slide, please. Survival of the babies, that's the slide I think we can skip because I think we'll spend want to spend a little bit more time on the next slide. Let's skip to the next slide, please. So this is, where are we? Can you go to the next, please? Yeah, the same study published in 1991, the references in the bottom for all these slides. And the duration of disease, you can see it is that typically they present between the day of life 2 to day of life 8. Calmness highest was between day of life 2 to 3, and then between day of life about like 36 cases, and 6 to 8 days of life was about 42 cases. So typical presentation is between the day of life 2 to 8 in the setup of this study, and I think we can probably try to apply it in our setup also in Pakistan. This data. Next slide, please. And as you can see in that slide, the mortality rate was lower when the infant present early or late. And I don't know why the mortality data was lower in infants who presented greater than 8 days of life. I don't know. I have to go through that that article again, but this is what their conclusion was. Next slide, please. So now coming back to the herpes, we talked about the virology, we talked about the herpes, we talked about the transmission, we talked about the primary, non-primary, and all that stuff. We talked about the clinical presentation and its association with mortality between the two major groups of disseminated and CNS infection. Now, if we by this time have narrowed down any child or any infant that presented that we are thinking this is herpes, then this is what the treatment plan is going to be. The CSF has to be taken for herpes simplex virus DNA PCR, and the viral cultures should be obtained from the vesicular lesion, from the mucous membrane, from the conjunctiva. You have to do a liver function test, especially ALT, which is usually going to be high, and then you start acyclovir at a dose of 60 milligram per kg per day, divided in 3 doses, or 20 milligram per kg per dose every 8 hours. And then once you confirm based on those, from the big box, go down to the second 2 boxes. If there's an evidence of disease, then based on the disseminated disease, you'll treat it for 21 days. CNS disease is also treated for 21 days. Skin, eye, and mouth disease is treated even for 14 days. And if there is no evidence of herpes in the PCR, herpes in the PCR sample of CSF, then we discontinue. And then after the treatment, the oral suppressive therapy has to be continued for up to 6 months. This is what the guru from Alabama are recommending. This lady, Pininiti, is also associated with Dr. Richard Whitley. So she's now her junior faculty member with the same group. Next slide, please. Complications, 70% of the herpes simplex encephalitis lead to death. We already know from that 1991 study in the New England Journal of Medicine. With the high dose of acyclovir, 1-year mortality is reduced to 4% for CNS disease, and to 29% for disseminated disease. And then even if these infants survive, they have long-term complications like microcephaly, hydrocephaly, porencephalic cyst, spasticity. So even if you treat these infants and they survive, they will develop complications. So remember that part. Next slide, please. Now, this is the one that I want all of you to pay attention to. Remember that I said to you that herpes is more common in Africa and least common in Southeast Asia, and somewhere in between is United States and Europe. Actually, Europe has a higher rate of herpes as compared to United States. But if this is actually a very well done study, and it was a good way of documenting the prevalence of global estimate of, went to different regions, collected the data, used some mathematical and statistical equations. And you can go through this article, this prevalence data. And if you look at it, I highlighted the Southeast Asia, both in the HSV1 infection category and HSV2 infection category. And if you look at the HSV1 infection in Southeast Asia, and then according to the age group, if you look at the top of the table, they have the maternal age group divided into different ages: 15 to 19, 20 to 24, 25 to 29, and so on and so forth. And this prevalence is per 100,000 live birth, not 1,000, not 100,000, not per 100,000 live births. So remember that. The prevalence is very uncommon if you look at in the herpes simplex virus 1 infection in Southeast Asia, especially in all age group, from 15 to all the way up to 49. And it is between 0.5 to even as low as 0.06. Study. All means South and North America, in my opinion, when I reviewed this study. So again, I'm not talking about what is the relevance of it, the American data into this, but look at the Southeast Asia data, that how low and how less prevalent herpes is in Southeast Asia, and then we can try to utilize this data in Pakistani setup. Next slide, please. Now, how uncommon herpes is in USA? I think they say about 1,500 cases are diagnosed annually with a birth cohort of 4 million. 1 in 4 and 5 adults have HSV2. HSV prevalence varies between 20 to 50% cases of genital herpes. So even in US, where there are 4 million populations annually, pretty risky behavior, almost as risky as any part of the world other than Southeast Asia. The occurrence of HSV is fairly rare, 1,500 cases. I should say in probably 15 years, I might have seen like 2 or 3 cases in total. Next slide, please. So let's try to summarize, okay? And I'm going to give you my summary, and we can have the discussion on further on that how we can apply it. That maternal herpes may or may not be present clinically. We know that from going through the previous slides. Spouses may or may not be faithful to each other. We are human beings. Risky behaviors are common. Inadvertent HSV1 transmission may happen if mother, father, relative had cold sores and might cause infection. So remember that part. Infant can present between day of life 4 to as far as day of life 19 based on the studies that we are aware of. Whitley study of 1991 published in NEJM, and then Kimberlin data from 2014. And by the way, David Kimberlin is also part of the faculty of Richard Whitley, same as Pininiti. Clinical presentation will not tell us that I'm herpes. So if a baby is presenting or infant is presenting with signs and symptoms, it's not going to be clinical 100% sure until unless you see the vascular lesion. It can be just a very sick kid with seizures and associated DIC and liver dysfunction. There is no clinical test that can help us in differentiating between GBS sepsis, listeria, gram-negative infection, or any viremia until and unless we have a culture. Any clinical feature we talked about, it can be seen with GBS sepsis, it can be seen with listeriosis, it can be seen with a gram-negative infection, or even viremia. Remember the study that we talked about, 576 infants with 37 having positive something in the CNS, in the CSF, and 12 had enteroviral infection. So remember that part. And then how about you guys think about writing a diagnostic approach? And let's take a break of 30 seconds, and I'll give you my diagnostic approach, what I would do in a Pakistani setup. So let's take a pause of 30 seconds. Think in your mind how you want to do a summary or do a diagnostic approach in a setup like Pakistan, where we do not have herpes antibody testing available and we do not have a herpes PCR available. And 30 seconds starts now. Okay, let's go to the next slide. So what would I do? And I'm talking about me going back in time and becoming a fellow again. And now knowing and attended this presentation, this is how I would summarize. I would take a good history. I will go and talk to the mom, talk about everything, okay? Ask about labor. How was the labor? How was birth? Was there any history of itchiness, red dots noted by mother? And this history has to be taken by somebody who can talk to the mom privately in a very, very confidential way. And I would discuss the history of birth trauma, shoulder dystocia, or accidental fall. Remember, the median day of presentation is 8 or 9 days, and some of these babies may have been born to in a setup where there may be a birth asphyxia and the kid is presenting a little later at your tertiary center. I will ask one of my female colleagues to talk to the mother in private with respect and with dignity, that whether she had other partners, and don't try to be judgmental. This is, I always, when I'm asking these private questions, I explain to the parents that this is not in any way, shape, or form being judgmental. I'm trying to help their child. We'll ask father privately if he was faithful. How did the mother noted that the infant was getting sicker? I would ask mother, did the infant progress from alert, lethargy, semi-comatose to comatose? Remember Richard Whitley's study we talked about. I will do a full detailed examination, including paying special attention to the CNS status, any vesicles, petechiae, breathing difficulty. Okay. And then I will document the presence of cutaneous lesions. And I can actually take the picture with parents' permission to see whether they are regressing with treatment or progressing with treatment. And then I have one of my female colleagues go and examine the mother's genitalia. Next slide. I will establish an IV access, draw the labs, including CBC, CMP, blood and urine culture, PT and APTT. I will load a first dose of ampicillin, meningitic, 100 milligram per kg per dose, Q8 hours, or 75 milligram per kg per dose every 6 hours, total dose of 300 milligram per kg, depending upon what day of life the infant has presented. I will start with gentamicin, 1 dose. I actually love both these two antibiotics, but in a setup like Pakistan, where there may be like a chances of what do you call as resistance, you can skip gentamicin and use either cefotaxime or ceftazidime. I will not start acyclovir until unless my clinical history and examination is suggestive of something, because I'll explain it to you later. And once the CBC result is back and there's no thrombocytopenia, I'm going to do a lumbar puncture. If infant is lethargic, comatose, semi-comatose, a seizure, any of those CNS symptoms, I'm going to do a lumbar puncture on that infant. And that's why I would examine the infant. And then when I look at the labs, there may be mild or moderate hypo or hypernatremia, which can be an incidental finding. Remember, any CNS disease or any severe infection can cause syndrome of inappropriate antidiuretic hormone secretion or dehydration. SIADH will lead to hyponatremia of mild variety, and dehydration can cause hypernatremia until and unless sodium is less than 128 or greater than 155. I would not start getting focused on hyper or hyponatremia as the reason of illness in this infant. I will still continue with antibiotics, even if my sodium is between 128 and 155. Okay. Obviously, I'll be treating the electrolyte imbalance, but I will continue with the antibiotics. Okay. And then if the infant is what you call as stable enough, I'm going to go ahead and do a CSF and look for the appearance of it, whether it's turbic or opaque. If it is turbic or opaque, bacterial infection is highly likely. If it is blood tinged and the clinician is sure that she or he did not add a vessel, then HSV is a very high probability. But again, it all depends upon your skill. If you touch a vessel while doing a lumbar puncture and there's a slight blood tinge, it may be because of your traumatic tap and may or may not be related to herpes. So try to stitch together all the clinical data and clinical findings with your CSF result, and then make a decision about acyclovir or no acyclovir. Next slide, please. At this point in time, as I said, because of the high the index of suspicion for herpes, I can start the acyclovir. Always remember, acyclovir is extremely vascular toxic. None of my nurses will let me start an acyclovir until and unless there's a central IV access. So either you have a UVC or a PICC line, because the acyclovir will burn the vessel within 24 hours, and you will need to keep rotating, and you will run out of the sites if you want to treat it for 21 days in a confirmed case of herpes. Continue the AMGENT coverage, and again, if your index of suspicion is for herpes, continue with the acyclovir. Now, if the blood cultures 48 hours later, blood cultures turn up positive for the growth of any bacteria, then you can safely assume that the meningitis or the CNS symptoms were because of that particular bacteria, and you can DC the acyclovir. Okay. If the blood and the urine culture remain negative, then it's a dilemma. And the dilemma is that these cultures reliable? Okay, and should we continue? No, all three, like Amgen and acyclovir, not knowing what we are treating, or should we drop acyclovir? So I think this decision has to be taken based on the fact that how reliable your blood culture was, how reliable your urine culture was, and we know we cannot do a herpes PCR in Pakistan. And so that's why if you recall, I constantly emphasize blood cultures has to be drawn in a very aseptic way and sent to a reliable lab, so that if they turn up positive or negative, then we can safely assume what we are treating and how we want to treat it. Now, the only reason in my perspective to continue with acyclovir is that if my history and clinical examination reveals something, or even if my clinical history and clinical examination did not reveal something, but at the same time, I have a very high index of suspicion, not believing the mom's history and everything, I would probably continue with the acyclovir. And if I want to treat it as herpes encephalitis, I definitely would need a central IVF. Next slide, please. Dr. Moveen Rathore, I actually talked about him probably like a week ago, that he is an infectious disease specialist. And he just shared an article with us about like a couple of weeks ago that he published of 3 cases, confirmed cases of herpes encephalitis, and the CSF findings. You can see that, the CSF doesn't appear terribly, abnormal. Like white cell count in the case 1 was 34. With a protein level of 174. It is suggestive of abnormal CSF, but it has no specific features that would say that this is herpes. 34 WBCs, 174 protein in one case. There was only 1 WBC and actually a normal or near normal protein level in the second case. And go to the third one. Next slide, please. Junaid, next slide. Next, yeah. And then in the third one, if you look at it, there were only 3 WBCs with a protein of 99. So what I'm trying to say is that if you look at those 3, and the article, I have shared the online access of that article, that if you look at those CSF cases and CSF of those cases where the herpes PCR confirmed the presence of herpes in the CSF itself wasn't speaking loudly or screaming that I have herpes. So as I said, there is no right or wrong thing in a Pakistani setup, knowing that we cannot do a PCR because the CSF analysis is not going to give you any specific clue. Next slide, please. Now, this is why I want to talk to you guys very importantly. So how to prevent a maternal herpes simplex virus acquisition during pregnancy? And don't look at the first two dots, look at the third one. And I want to read it for you. And it is also published by Pininiti and David Kimberlin. The third approach to prevent maternal HSV acquisition during pregnancy, I'm talking about the third dot, is to advise all pregnant women to abstain from all forms of sexual contact during the 3rd trimester of pregnancy. The final approach might particularly be applicable in situations where serologic testing is either unavailable or is not economically feasible. So that's the only thing I can recommend for Pakistan. Next slide, please. So then at the end, once I was done with it, I ended up writing to Richard Whitley, the one who was the author of the original study from 1991. And he is pretty much the author of any study that is being published, along with either Pininiti or David Kimberlin. And I gave him my brief introduction. He was very gracious enough to reply me right away. So my first question was, most herpes encephalitis in neonate is caused by HSV2. At least this is what I knew. But based on a 2017 JAMA study, HSV1 is also causing neonatal encephalitis. Is HSV1 transmitted by mother who had cold sore by skin contact / kissing? And he said this is correct. My second question was, in a conservative society like Pakistan, where risky behaviors are not very common, and a monogamous relationship whereby mother never had any history of multiple sexual encounters, can a neonate develop herpes in the absence of any lesions? And if his answer was, if the family has orogenital sex, most certainly. And in my third question was, in a setup where herpes PCR is not available, is it okay to continue acyclovir based on clinical suspicion? And he said yes. And that's where I think was the question that was raised by Naveed. And my reply at that time was that I don't know, or something like that. But this is what his answer coming from the person who is a leading expert in herpes. And next slide. Thank you very much, everybody, for listening. If you guys have any questions, feel free to ask me.
Thank you, Nasir. Very elaborative and very comprehensive. There are 2-3 things. Okay, your third point in prevention, it cannot be possible. It's the least possible in Pakistan. The second two, maybe we develop our medical system can possible. The third one is least possible in Pakistan in anything. The other thing is that we are not conservative society anymore. Okay, so we have all kind of problems. What the West have, we have it. My question is, why you are saying PCR is not available? PCR is available in Pakistan.
I was told, I don't know, maybe I followed the wrong thread. I was under the impression that it's not available universally in Pakistan. Am I correct? I think it is available in Ahan and maybe in Islamabad, but not sure about Peshawar and other areas.
No.
Correct me if I'm wrong.
Yeah, I think it available in everywhere in Pakistan and Chuktai lab, and it is not very. I send you the price or Naveed is only 5,000 rupees. So the PCR and the herpes antibodies tests are available in Pakistan. Now,
okay, well,
so let's see what the people ask question to you. Okay, there are a few questions. So can we go ahead, Nasir? And then
sure.
Then we will allow the audience to ask. So the first question is, thank you for your wonderful lecture. If the mother has remote history of genital HSV and is on suppressive valcyclovir, how does it affect the transmission to HSV to neonate?
If mother had again, go back into the recurrent thing. If mother had a history in the past and she's on oral suppressive and there's no active lesion, typically what they do is that they let them deliver vaginally. American College of OBGYN let them deliver vaginally. If there are active lesions, then they will do a C-section. So if there's no lesion and mom is on suppressive therapy and she had herpes in the past, I think it's okay not to. It means like you should have an index of suspicion because, as I said, the transmissibility can happen and the infant present with symptoms. You should have it as in your differential diagnosis, but the transmissibility risk is very low. I think we talked about it in the slides about like 2%, something like that.
Yeah. So my question is that, Nasir, if I think you went through that article, why the transmissibility in the recurrent infection is only 2%? What is the reason for that? Let's say the mother has active lesion and a recurrent. So why still the baby has only 2% chances as compared to the 57% or 21% in other groups, 25%?
I think if you recall, Jeanette, that one of the slides that we talked about is when we were talking about the transmissibility, slide 23, risk factors for transmission of herpes simplex virus to neonate. And if you look at it, it talked about the antibody status. The number 2 point was the maternal HSV antibody status. Yeah. So my understanding is that, and again, I'm not an expert in virology, is that if a mother has recurrent infections and she develops antibodies, and if those antibodies are circulating in her blood system, they are transmitted to the baby. And that's why there is a chance of acquiring infection in infant is less if their mother has a history of recurrent infection. That's my understanding. I may be wrong.
Yeah. Okay. So can we go for the CT scan in case of neonate with HSVC infection? As in our setup, we recently received a 10-year-old patient with hypo and hypertense area in parieto-temporal region with PCR positive for HSV1.
Yes.
So he's asking about the CT scan.
Yes, CT can be done, but the common misnomer or common thing that we think that it has predilection for temporal lobe, it is more common in more mature or adult patient or children. But in neonate, there is no I can share an article with you guys where they did MRIs on infants who had herpes, confirmed herpes encephalitis, and it presents with a global picture. So until and unless you pair it with a herpes PCR, the MRI itself does not is very, what do you call it, specific. There's no specific finding in MRI that will say that this is always associated with herpes, unlike in adult where there is a temporal lobe predilection for herpes type 1 encephalitis to be localized on CT or
Sure.
MRI.
We already talked about the CSF. Now, the Yasser is asking role of acyclovir prophylaxis following CNS or disseminated disease, duration. So
6 months.
6
6
months.
months after 6 months. I remember the what's the slide number? I can share it with you. Yeah, you guys probably remember that.
Yeah.
Slide number 34, and it talks about CNS and disseminated disease 21 and skin, eye, and mouth disease for 14 days. So if an infant has a skin, eye, and mouth disease and no systemic symptoms, you should be treating it still for 41 days, and then with oral acyclovir therapy for 6 months.
Okay, so this is the old question, and you can ask, is important also all the time. The people ask, can we continue the breastfeeding in neonate diagnosed with HSVC positive?
Yeah, depending upon what's the status of the baby. If the baby is alert, then that means that the survivability is going to be good on that baby. But you're like, I don't know. Usually, most of the
I think she's asking about the contraindications of the breastfeeding. So just for answer this question, the HSVC is not the HSV is not the contraindicated. If the baby is fine, he can have a direct breastfeeding from the mother. So it's nothing to do with anything transmissibility or this thing. Then when to start antiviral therapy, either to confirm first by culture or PCR?
Nope. If you have an index of suspicion, you start the as I said, remember in my, what would NASIR RASHID do? I said, start the acyclovir by the time you are done with your initial testing. And by the time you are doing a CSF sample, you should make up your mind whether you want to continue at least for 48 hours minimum. And go back to the slide number. Let me finish. Just one slide. 34. Slide 34 talks about it, that once you confirm, until you confirm it, you start acyclovir, no matter what you think. At least start it until you confirm or deny, then you can DC it.
Okay. That's fine. The PCR, how frequently? Okay. Now we talk about the 6 month thing, and then the CBC creatinine. You have how often you are doing if you are giving acyclovir?
The creatinine level. Usually every couple of days, because obviously there's liver. If you are using 2 nephrotoxic drugs, gentamicin along with it, and you're not dropping it, I would do at least 1 by the day of life by day of life 2 or 3, like day of admission 2 or 3. By that time, we should decide that are we continuing with gentamicin or not, because once we drop the gentamicin, then I think creatinine needs to be done every weekly just to be sure, and just basing on the urine output, I think you can easily figure out how the kid is behaving.
Yeah, we are doing weekly with the acyclovir and for the neutropenia also. The other question in my mind, as we are talking about the side effect of acyclovir, you mentioned about the IV burn or the peripheral vein burn because of the acyclovir. Just to add into that you have an option to give very slow over the 1 hour period of the acyclovir, because sometimes you don't have the central line, and in our setup in Pakistan sometimes is really difficult to have central line. So but if you give over a long period of a time, it helps to reduce the IV burn. So that's just the error. But ideally what Nasir said, that you have to have central line or UVC or PIC line. Okay, so the other question is that the C-section recommended in SSV, what are the, so we already talked about Naveed asking that the C-section recommended in all HSV pregnancies. What are the ACOG, RCOG, and Canadian guidelines?
ACOG guidelines are simple and straightforward at 36 weeks. all mothers are screened by, like if they have a history of herpes in the past, they are examined by their respective obstetrician. If there is an active lesion, they start on suppressive therapy until they deliver. And at the time of delivery, if there's any active lesion, then the mother get a C-section. If there is no active lesion, then they let the infant deliver vaginally.
Okay, one very common question, role of repeat CSF after 21 days of antiviral.
No, I wouldn't. I don't think so. There was any recommendation on that, in my opinion.
Neuroimaging role we already discussed. Do we get hepatitis in CNS disease?
No.
No.
Hepatitis, no. So hepatitis as a term, remember in the disseminated disease, you will get liver dysfunction. So you
That
will
is
get
called,
hepatitis.
yeah, that is called
Disseminated.
hepatic encephalopathy, which is totally different entity.
Yeah.
But anyway, disseminated herpes.
Sir,
Yes,
actually,
sir.
in the continuation of this question, role of repeat CSF after 21 days. So it is, I think it is mentioned in the New Reviews article, where it was written, repeat the CSF after 21 days, and again it is PCR positive, then you can continue one more week to treat the baby.
Yeah. It's a different approaches. But people are doing differently. But anyway, we had few cases of herpes, but we didn't never repeat it. But anyway, this is good. Saeed, thank you very much. Again, the same question, role of IVIG. Nasir?
Nope.
Nope.
Not to my knowledge. Again,
Okay.
I read 20 plus articles. I did not recall any role of
Okay.
IVIG.
So, Dr. Sabir from Peshawar, I think, how will we know about resistance to acyclovir? If there is a resistance, then what alternative antiviral can be used, as Foscarnet is not available in Pakistan? Professor Sabir Khan. Okay, second question is the dose mentioned by you is not so high, 10 milligram per kg per dose?
No. So I recommended the CNS or disseminated dose is 20 milligram per kg per dose Q8 hour, or total dose of 60 milligram per kg. And there is no documented literature that says there is a resistance to acyclovir in the herpes.
Because we are not using acyclovir left and right. So this is the end from my side. The audience, or Saeed, you go ahead if you have any questions.
No, sir, I think all the aspect of the topic is covered beautifully. Any question from audience sides, he or she can ask. The Professor Talal is also with us. Sir, any question from your side, sir?
No, thank you very much. I think nicely elaborated. बिल्कुल कोई शक नहीं, ये हिस्ट्री में सारा कुछ जब तक नहीं होगा तो हम कैसे पहुंचेंगे डायग्नोसिस में. बट अनफॉर्चुनेटली बिकॉज ऑफ आवर सोशल कल्चर एंड आवर हेल्थ केयर फैसिलिटीज एंड आवर डेमोग्राफिक्स, बहुत मुश्किल है नासिर साहब ये सारी चीज़ें हिस्ट्री में पता करना. मैं आपकी बात से 100% एग्री करता हूँ कि यस, बगैर हिस्ट्री के डायग्नोसिस नहीं बन सकता. बट अनफॉर्चुनेटली कुछ हमारी सोशल और डेमोग्राफिक सेटअप्स ऐसे हैं कि वेयर आई एम नाउडेज प्रैक्टिसिंग, आई यूज्ड टू प्रैक्टिस इन, I've done lot of, मेरी ट्रेनिंग तो सारी यूके की है खैर, लेकिन उसके बाद पिंडी, इस्लामाबाद, लाहौर, एंड नाउ आई एम प्रैक्टिसिंग एट खारियाँ. एंड जो बच्चे हमारे पास आते हैं, हिस्ट्री तो बड़ी दूर की बात है ऑनेस्टली, बट यस आई फुली एग्री, बगैर हिस्ट्री के बात बनती नहीं है. ठीक, लेकिन हिस्ट्री लेना भी बहुत मुश्किल है. और बच्चा आता है हमारे पास नाना या दादा के साथ या दादी के साथ या खाला के साथ और फूफो के साथ, और माँ जो है वो किसी और हॉस्पिटल में है और बच्चा किसी और हॉस्पिटल में. ऑल गवर्नमेंट हॉस्पिटल्स इन पाकिस्तान डू फेस सच डिलेमास. ह्यूज अमाउंट ऑफ पॉपुलेशन इन आवर पार्ट ऑफ द वर्ल्ड और मदर कहीं है और बच्चा कहीं है. So that's a genuine problem, but that's not for, obviously वो तो हेल्थ केयर सिस्टम ऐसा है. एंड आई अप्रिशिएट आप जो कह रहे हैं वो 100% ठीक है कि हिस्ट्री होनी चाहिए, नो डाउट. That's my 2 pence.
Thank you.
Yeah, and then I thank you very much for re-enlightening me about the change in the socio-economic interaction in Pakistan, because भाई मैं जब 2002 में छोड़ के गया था पाकिस्तान, तो I think it was fairly conservative, but I don't know, it has changed
नहीं
over
नहीं,
the last years.
कंजर्वेटिव की बात नहीं है डॉक्टर साहब, नहीं नहीं, वो मैं कंजर्वेटिव वाला एंगल नहीं कह रहा। ये जो आप हिस्ट्री में सारी चीजें पूछ रही हैं, ये बहुत मुश्किल है माँ से। अव्वल तो माँ की अवेलेबिलिटी नहीं होती, ठीक।
जी जी
माँ
जी जी
कहीं होती है, बच्चा कहीं होता है। गवर्नमेंट I'm not talking about PKUs and Shifas and yes CMHs and things, ठीक, जो हमारे बाकी सेटअप्स हैं उनमें। और फिर वो वाली हिस्ट्री जो आप पूछ रहे हैं, वो बिल्कुल होनी चाहिए। आई एम एब्सोल्युटली, उसके बगैर कैसे गुजारा है? नहीं डायग्नोज हो सकता हर्पीज, नो डाउट, हो ही नहीं सकता डायग्नोज जब तक आप जेनिटल वार्ड्स की और जेनिटल उसकी हिस्ट्री नहीं लेंगे। लेकिन वो हिस्ट्री लेना वो बहुत मुश्किल और एक काफी नॉन टेंजिबल सी चीज बन जाती है हमारे सेटअप में, क्योंकि माँ कहीं, बच्चा कहीं, और उसके सर्कमस्टांसेस कुछ और। सो वो सारा चक्कर है, बट यस, इट हैज टू बी डन।
Okay. So with that, the only one question, Nasir, I have, you mentioned PT, PTT. You are doing PT, PTT in every baby? Yeah, Nasir, can you unmute yourself?
Yes, let me unmute myself. Sorry about that.
Yeah.
नहीं, मैं अपने सेटअप में अगर टैप कर रहा होता हूँ, अगर मेरे पास एक बच्चा आता है जो disseminated disease that I'm thinking it's like a severe infection, so
Yes,
I'm
yeah.
thinking in all directions, तो उसमें
Yes.
तो मैं इसलिए करता हूँ as part of a supportive
Yeah, exactly.
understanding, but it's not part of my herpes. Yeah,
Yeah,
definitely. I was
definitely.
talking about the broader picture of a presentation.
That's my whole point.
Yeah.
So with that, this is it from my side. Sir, Professor Khalida, if you have any comment, anything, Naveed, if you have any comment, anything, please.
Sir, here is Dr. Kokab. Nasir is raising the hand. I think he want to say something.
Sure.
Yes, go ahead. Yes, Kokab. Yes, Kokab.
Assalamu alaikum. Thank you for
Walaikum
the
salam.
beautiful lecture. So I have a question which is not related with Pakistani setup. So sorry, लेकिन आपने study कर लिया है, so I'm going to use your help.
Yeah.
Most common problem I come across is that mom has antibody positive, HSV positive, but she is not taking medicine. It's a vaginal delivery, no lesions. Do we need to do the skin culture?
I would do the skin culture. If mother is not taking antiviral suppressive therapy, I would, because there will be subclinical shedding, there will be asymptomatic subclinical. Remember the subclinical shedding and recurrent part we talked about? He may be subclinical shedding and
Okay.
I would do the culture. There's actually an article, Dr. Kokab, I can send it to you separately, where they talk about specifically these kind of situations.
Okay.
I just need to find it. Yeah, I can send it to you privately.
Thank you.
Thank you.
Okay, so that's it. Thank you, Nasir. Thank you very much.
Sir, Dr. Naveed is saying something.
Thank you, Nasir. Very nice presentation. Just two questions. एक सवाल तो यह है कि once the baby is born, the surface swab should not be taken immediately. It has to be a delay of 12 hours just for cross contamination. And other thing, like in Pakistan, you have seen like the 1 or 3, 4 babies are in one incubator or under the warmer. And God forbid, one kid is having herpes. So how we are going to isolate these kids, like to prevent the outbreak in the NICU?
So remember, Naveed, when we were talking about the basic virology and the transmission, honestly, if I'm suspecting highly neonatal herpes in an infant, I would not have that infant share the isolate or the cot with any other infant. I would say, let's just isolate that kid from anybody else. In fact, the nurse assignment should be different for that baby, because you don't want that nurse to be touching the baby and touching another baby. But remember the intimate contact part and all that thing we talked about? I think the baby has to be very closely in touch with another baby and active herpetic lesions like vesicles. If you have something like that, then the risk of transmissibility is very high. as in the same way as an or adult patient with cold sores kissing the baby repeatedly. But I would say I would isolate that baby. I would not want that baby to be with any other baby, in my opinion.
So, Naveed, the answer to your question, first of all, it is extremely difficult. If you are suspecting a herpes case and not an open lesion or this thing, then it's very difficult in our setup to isolate. We don't have beds, we don't have any facilities to do that. And as Nasir said, that for transmitting the herpes, it's not only the close contact, but it really has a very active lesions to transmit. I don't know the right answer, but the thing is that unless and until it is very active open lesions there, it's you can do whatever we are doing, because there is no way we can isolate those babies. We don't have beds, actually. That's a reality.
Right. Sir, Dr. Danish Makbul is also want to say something. Dr. Danish?
Thank you very much, sir. I have a question. So, for instance, can disseminated herpes present earlier than 10? Can disseminated herpes present?
Like a shot and
Sorry, Danish, somebody is talking behind. So I don't know. Can you repeat your question again?
Yes, sir, absolutely. Thank you. Sir, I have a question. Can disseminated herpes present earlier than 10th to 12th day of life in a preterm neonate?
Yes. Diseases do not read books. So we think that the 10 to 12 days, actually in a preterm infant, it can present very early because their immunological status is not as mature as a term infant. So if you are suspecting herpes in a preterm, it can present as early as, like, remember the Richard Whitley study? The mean presentation time was 4.8 days, plus minus 0.5. So it can present even a day of life 3 or 2.
All right, thank you.
Okay.
Any comment from Professor Khalid's side, sir?
Nahi, mashallah, very good presentation. Thank you very much. All the questions have been answered. Very good. Thank you.
Thank you.
Okay, Nasir, enjoy your Saturday.
Sorry to interrupt. Just one quick question. So I want your call.
यहाँ पे बड़ा अच्छा बेहतर हो रहा है. You are asking question and me and Nasir want to go outside. Okay, no, go ahead.
So when sending home with a history, and then we have done the baby's doing fine, and we are sending them, giving mom guidance to watch the symptoms. So most of the babies have erythema toxicum. And so how do I tell that, okay, what kind of rash to look for to worry about that, okay, this could be HSV. If there's no other symptom, just telling about that. If there is any rash, call or come back immediately.
I honestly, Dr. Nasir, what I do is that we actually show them a picture of erythema toxicum, and the vesicular lesion of herpes are a little bit bigger than erythema toxicum. And there are times that there is severe erythema toxicum that confuse all of us. You know, like I'm sure you must have had a few cases where you look at it and you say, damn it, I cannot say it is erythema toxicum versus herpes. So in that situation, I would err on the side of treating or like watching or keeping the baby in the unit. But if it is like a minor eruption, you can actually explain it to the mom. And then again, depending upon how compliant that mom is, that is very important, because sometimes I end up keeping those babies if I think the mom is a very young mom, like a 16 or 17 high school kid, and she may lost to follow up. I don't send those kids home. I just leave them in the unit and say, you know what, let's just observe it in a setup rather than taking a chance. Because the last thing you and I want in a setup like where we are is to send this baby home and turn up in another emergency room with severe infection. And then it will circle back to who saw the baby last time. And you don't want your name and I don't want my name on that chart. So yeah, I think showing a picture and getting a more detailed discussion is also probably helpful, in my opinion.
Thank you.
Thank you.
Yep, thank you.
I think, sir, we should conclude the session if Dr. Junaid is low and our all rest teachers.
Yeah, we will now, because it's more than
Yes, sir. So I
So-
think that was a very wonderful session today on the neonatal herpes encephalitis. So once again, thank you so much, sir, Dr. NASIR RASHID, and thank you so much, Professor Khalid Haq, and Professor Talal Wakar, Professor Junaid Muhib Khan, and Dr. Naveed Mandurani, and all my respected seniors and dear colleagues. So inshallah, again, next week, another interesting topic we will discuss, which is inborn error of metabolism, present like HIE. So our speaker will be Dr. Bushra Afroz from AKU. So inshallah, till that, Allah Hafiz. Thank you once again.
Thank you.
Thank you.
Shukriya.
Thank you, Nasir. Thank you very much.
Thank you. Thank you.